Okay, ladies and gentlemen, now I would like to move on to the next session. So the next session is three paper presentations from rising stars in the Asia Pacific from Thailand, Bahrain, Malaysia, Laos, and Philippines. So Professor Somchai Leelakusolvong will remain on the panel as a moderator. He is the current president of the Gastroenterological Association of Thailand, and he is from the Faculty of Medicine at Siriraj Hospital. And our second moderator is Professor Joel Townlin. Professor Joel Townlin is the Professor Emeritus at the National Taiwan University. He is the honorary president of the Digestive Endoscopy Society of Taiwan, and he is the honorary president of the Gastroenterological Society of Taiwan.
Thank you very much, Ted. Welcome to the free paper presentation from Rising Star in the GI 2024. Today, as Ted already mentioned, that I will be a moderator and we have a co-moderator is Professor Joe Taolin from Taiwan. I think everyone will know him very well. We will have a five presenter. Maybe let's start with the first one. I will start. The first one is Professor Dr. Natsuda Aumpan from Thammasat University. Currently, she is a medical instructor at the Thammasat University. She is going to deliver a paper entitled Long-Term Efficacy and Safety of Encapsulated Fecal Microbiota Transplantation and FMT via Rectal Enema for Irritable Bowel Syndrome, a prospective cohort study. Dr. Natsuda, please.
Thank you, Professor, for your kind introduction. Mr. Chairman, ladies and gentlemen, I am Dr. Natsuda Aumpan from Thammasat University. Today I am going to touch on the topic of long-term efficacy and safety of encapsulated FMT and FMT via rectal enema for IBS. All authors have no conflict of interest to declare. IBS is a common functional bowel disorder. Gut dysbiosis contributes to the pathogenesis of IBS. Fecal microbiota transplantation is an administration of fecal solution from a donor into an intestinal tract of a recipient. So FMT could be a possible treatment option to restore normal gut microbiota in IBS patients. In previous studies, demonstrated that FMT could provide tentative benefits in IBS patients. However, these studies mostly use invasive techniques for FMT. So in our first FMT study, we compared efficacy of encapsulated FMT, FMT with rectal enema, and placebo in IBS patients, and we found that FMT capsules and rectal enema significantly improve IBS symptom severity score, clinical response, abdominal symptoms, and also quality of life at 4 and 12 weeks. So in this present study, we aim to determine efficacy and predictors of long-term clinical response of FMT in IBS patients. This study is a prospective cohort study. We included Thai patients aged from 18 to 70 years old with IBS diagnosed by Rome 4 criteria who received FMT at Thammasat University Hospital between April 2021 and November 2022. In our first trial, we included patients and IBS patients and excluded patients who are with severe comorbidity and pregnant women. After that, we randomized patients into 3 groups, which were FMT with rectal enema, encapsulated FMT, and placebo. In this patient study, we follow patients in 2 groups, and we recorded IBS symptom severity score, quality of life, adverse event, factors associated with FMT response, and also we collected stool for microbiota analysis at 1 year after FMT. The primary objective was to evaluate IBS-SSS at 1 year after receiving FMT, and secondary objectives were to evaluate quality of life, adverse event, predictors related to long-term clinical response, and changes in microbiota diversity at 1 year after FMT. All data were analyzed by SPSS version 22. We obtained informed consent from all patients. From the first table, there was no difference in baseline characteristics between groups. In this table, we show that both FMT groups provided significant short-term improvement of IBS-SSS, clinical response, and quality of life at 12 weeks after FMT. And also we show that FMT groups in both groups provided long-term improvement of IBS symptom severity score and quality of life at 1 year. There was no difference in IBS-SSS score, clinical response, and quality of life at 1 year between two FMT groups. You can see from the figure that encapsulated FMT and FMT with rectal enema improved long-term IBS-SSS score and clinical response. If you look at 12 months, you can see that rectal enema group tended to have lower clinical response at 1 year than encapsulated FMT. We also evaluate factors is associated with long-term clinical response after FMT, and we found that probiotic consumption and high fiber diet were significantly associated with sustained clinical outcomes. There were only minor adverse events in all groups, and no serious adverse event was observed. About fecal microbiota analysis, we demonstrated significantly higher alpha diversity at 1 year after encapsulated FMT. So this is a prospective cohort study to determine long-term efficacy of encapsulated FMT and FMT via rectal enema for IBS patients. Prior studies demonstrated long-term improvement of IBS symptoms, but they use invasive procedures. Our study provided significant improvement of IBS symptoms at long term by using less invasive FMT technique. Mr. Chairman, for my summary, encapsulated FMT and FMT via rectal enema provided high efficacy and long-term response, including clinical response, IBS-SSS score, and quality of life in IBS patients without serious adverse event. Probiotics and high fiber diet might be factors contributing to sustained clinical outcome. FMT is a microbiota-based medicine which has truly clinical potential and personalized approach for IBS treatment in the future. Thank you for your kind attention. I feel very honored to answer all of your questions.
Yeah, thank you very much. We have 2 minutes left for Q&A. Any questions from the floor? Dr. Natsuda, among these 3 groups of the patients who receive encapsulated FMT, and placebo, you also mentioned that the microbiota pattern have a alpha diversity. Any specific microbiota pattern change from before and after 1 year period? Do you have that data? Except because you already mentioned about the alpha diversity in these 3 groups.
Yes, about alpha diversity, there is significant improvement, but about specific strains, there was no specific strain that improved after FMT at 1 year. But at 3 months, there are specific strains.
But how about the side effect? No side effect in the FMT group?
FMT, in FMT group, there were only minor adverse events like nausea and vomiting and low-grade fever.
Sounds good. Okay. You didn't mention about the cost, no? The cost. Okay. It's okay. Yeah, thank you very much, Natsuda. Okay.
Thank you.
Yeah, please give a big hand for again. Let's move to the second. Yeah, Professor Jotaulin.
The second speaker will be Dr. Dalouny Sihalath. She is working in the Gastroenterology and Hepatology unit at Mahasot Hospital in Laos. Today, she will give us the talk about evaluation of the quality measures for colonoscopy in colorectal cancer screening among patients with Mahasot Hospital, Laos, a cross-sectional prospective study. Please.
Thank you, Professor, for your kind introduction. Good afternoon, ladies and gentlemen. My name is Dr. Dalouny from Laos. I would like to present evaluation of the quality of measure the colonoscopy in colorectal cancer screening among the patients in Mahasot Hospital, Vientiane, capital, Laos, PDR. This is a cross-sectional prospective study. As we know, the colorectal cancer is the third common cancer in worldwide and being the second leading cause of death. According to the data of the Global Grande 2022, they have the data about the 1.9 million new cases of colorectal cancer cases and about the 1 million deaths. And we know that burden of the colorectal cancer screening is rising the year by year. In Laos, the colorectal cancer is significant public health issue and ranking at the fourth most common cancer. For the colonoscopy, is the most effective screening method for colorectal cancer screening. It can identify the primary lesion and also they detect asymptomatic early stage. We can remove the polyp during the colonoscopy. We have the strong evidence that colorectal cancer screening has decreased the incidence and mortality of the colorectal cancer. However, colonoscopy is an imperfect method, has a variable quality. We can miss the lesion about 5 to 20% during we perform the colonoscopy. This study aims to evaluate the quality of colonoscopy for CRC screening. We would like to know the incidence of the colorectal polyp and also the adenoma detection rate in our center, as well as our colorectal cancer rate in our center. This is the screening tool for the colorectal cancer screening in many guidelines in the US and Europe guidelines is in average the age from the 50 to the 75 years old. For colonoscopy is invasive test that we perform every 10 years. We have like two methods. The most common for the CRC screening method for average is the age from patient from the 50 to the 75 years old. The first one is the one-step approach for CRC screening. We use perform like a colonoscopy, starting from patient from 50 years old. And the second one that we perform like a two-step approach for the CRC screening. That means we use the like a non-invasive test first. For example, for the FISH test. If the FISH test positive, then the proceed to perform like colonoscopy. It is very used common in Asia country because the country have like a limited resource and the shortage of endoscopy. This is the really useful. For the quality of indicator for the colonoscopy for the CRC screening, according to the guideline, the ASGE, the 2015 has a lot of parameter. The parameter has like a numeric requirement as shown that is this slide. For our study, we mainly focus on the would like to know the adenoma detection rate, the bowel cleansing quality according to the Boston bowel preparation scale. Would like to know success rate, such as the fecal intubation rate, withdrawal time, as well as the complication post-polypectomy. For the primary outcome, we would like to evaluate the quality of colonoscopy in setting of CRC screening in our center. For the secondary outcome, we would like to evaluate the parameter of the quality of the CRC screening, such as the bowel preparation quality according to the Boston bowel preparation scale, the success rate of the fecal about the fecal intubation rate and the withdrawal time, identify the polyp detection rate, including adenoma detection rate and advanced adenoma. The next one about would like to know about the complication rate post-polypectomy procedure. And the last one, to identify the correlation about the quality of colonoscopy and adenoma detection rate. This is a cross-sectional study we perform in our center in Mahasot Hospital in Vientiane as a referral center in Vientiane. Performed during 8 months. We include all the adult patients undergoing with complete colonoscopy for CRC screening. The patient from the 18 to the 75 years old with or without alarming symptom, or patient at least average risk for develop CRC screening. We exclude the patient the detail in this slide. The patient for the enrolled for the this study, we have like a 300 patient for enrolled for this study. Only 288 patients underwent to the colonoscopy for the CRC screening. We found that the male is not different proportion with the female. The mean is about 38 years old. And the most common indication for colonoscopy is the bowel habit change and the low rate of bleeding, and have the 10% of the significant weight loss. We found that the 95% had the success rate of the fecal intubation rate. And they have the found that for the bowel preparation quality is quite good. The mean that the Boston bowel preparation score is about 7. And we have like also the withdrawal time during the we perform the colonoscopy around mean time of the 8%, more than 50%. The withdrawal time more than 6 minutes. And in our study, we found that colorectal cancer is about 6%, is quite high. And adenoma detection rate in our study is about 28%, and 6% we found that advanced adenoma. We perform for analysis by various analysis of demographic data for the bowel preparation scale quality, withdrawal time, and adenoma detection. We found that the patient more than 50 years old is higher risk of the adenoma detection about 3 times. And when we perform the colonoscopy with the overall time more than 9%, we have the chance to detect adenoma about 4 times. And for the we perform also the multiple variate analysis of the demographic data, bowel preparation score, and the withdrawal time and adenoma detection rate. We found that the male for the male the have like more than 50 years old have higher risk adenoma detection rate than the patient have under the 50 years old. In the setting of the colorectal cancer, we found that 17 patients had the colorectal cancer. This total, the 6% of the colorectal cancer, they had at least locally advanced stage already. That means that we performed the colonoscopy, we found a big mass already. And there's many expertise that discussed in this morning. You can see the other patient about the 7 of the 17 patients, about the 40%, the patient is under the 50 years old. That means the patient has already the early onset of colorectal cancer already. I found the data from the colorectal cancer in ASEAN country. Many countries in ASEAN country have like a national CRC screening already. Some country does not exist yet. For in Laos, for the national CRC screening, we cannot establish yet for now. But you can see the colorectal cancer in Asian country is quite high. And I compare the quality of colonoscopy for the CRC screening compared to the neighborhood study and also the previous study. I think it's not too much different from the other center. However, this study had limitation. The study is conducted only one center. We cannot representative for the general population to perform the colonoscopy for CRC screening. The duration in our study is quite short, and the sample size is quite small. And we include all the patient in admission, not general population with asymptomatic. For conclusion, our study showed that indicator of quality of colonoscopy was acceptable, with result that indicating the average colorectal cancer at overall ADR is about the 28%, and we can achieve the adequate bowel cleansing about 97% of cases and high CGO intervention rate. And we have like appropriate withdrawal time as a protocol with the withdrawal time about the 8 minutes, and we have like also as well low complication rate post polypectomy. The last one, the results show that the age over the 50 years old is strongly associated with the increased ADR rate. And longer withdrawal time, more than 9% during colonoscopy, is linked to higher ADR. Thank you very much for your kind attention.
Okay. Yes, please.
Thank you. Nice presentation. How many colonoscopies are booked on your standard endoscopy list? So this is a practical question. In your hospital, how many colonoscopies will be booked in a morning?
We have in my center, it's not too much. It's about 10 patients per day.
10 patients in a morning?
Yes.
In a morning?
Yeah.
Good God. 10 patients. I'm a pretty good colonoscopist. I do a lot. 10 patients is a lot, and I thought it might be as high as that. In colorectal cancer screening in the UK, you are only screening colonoscopy is an hour, which is eye-watering. I can't spend an hour doing a colonoscopy. Okay, so that was, I suggest that that is a very, very high number. The second point, though, is about your last one, saying that the withdrawal time of more than 9 minutes was associated with an increased risk of adenoma detection. But hang on a moment. The 9-minute withdrawal, the longer you take in withdrawal, because it includes the removal of advanced adenomas, of course it takes longer time. So when you're removing adenomas, doing a complex polypectomy, then your withdrawal time goes up immediately. So I would be careful, because it's quite hard to spend 10 minutes just withdrawing a colonoscope in a normal colonoscopy. I'm not a specialist endoscopist, but I do a lot of procedures, and I just make that point.
Yeah. Thank you. Normally, in the standard colonoscopy, we should withdraw time at least 6 minutes. Yeah, but have the one RCT, that means that when we withdraw time is 9 minutes, it can be.
Yeah, I know that. It's just that it's biased.
Yes.
It's biased because it includes the
Yeah.
complex polypectomy time
Yeah.
as well.
Yes, thank you.
Another question?
No.
Not the question. Okay. I have just one comment. Your study is very good, but I suggest not to use the term of colorectal screening, because that in your patient, there are so many patients with symptomatic. For example, you have patient with body weight loss, even you have a bloody stool or something like that. That will be not indicated for screening. Screening is defined as a patient without any symptom. So the overall result just can reflect your colonoscopy quality, but not for screening.
Okay, thank
Thank
you.
you.
Thank you for your suggestion.
Just very short comment, because you mentioned the 4 or 5 cases of a colorectal cancer in the age group younger than 50. So go back to the rounds and see that why you have a lot of cases of the younger patient who have a colorectal cancer. You may have to consider to make an early screening, and not only 50, because like AGA now starting at the 45. Just back to the round. Okay, thank you very much.
Yeah, thank you very much.
I will move to the third presenter, Dr. Mohammad Al-Kuda. He is an associate professor of the physiology at Arabian Gulf University, Bahrain. He is going to deliver a talk of the study of the DMPNP as a novel anti-inflammatory treatment for colitis, a promising therapeutic approach for IBD. Mohammad, please.
Okay. Thank you for the introduction. It's my distinct pleasure to be here at the 4th ASEAN Stomach Gastroenterology Conference. I'm Mohammad Al-Kuda from Bahrain. Okay. So my presentation will be about a novel compound, a dimethyl pyridine, nitropyridine, as a novel anti-inflammatory treatment for colitis. As we all know, it's like inflammatory bowel diseases. They include both Crohn and colitis. Both are chronic conditions that affect the gastrointestinal tract, and they are relapsing, and they carry a debilitating symptoms that affect the quality of life and necessitate treatment. That's why the current pharmacological treatment for IBD, as you all know, there's like the anti-inflammatory drugs, including the amino salicylate and the corticosteroids, immune system suppressors, and the biologics like the anti-TNF alpha, and finally antibiotics. But because of the nature of the IBD and the relapsing effects, like we usually seek for better treatment and the treatments that can solve all the side effects and increase the efficacy and potency of treatment. That's why we try to see the effectiveness of a new compound, the dimethylpyrazole nitropyridine, as a potential treatment for, and it's like kind of a pyrazole derivatives found in various drugs with antimicrobial properties, hypoglycemic and anti-inflammatory. That's why the aim of our study was to see the effectiveness of this agent as a potential approach to treat IBD. In order to do so, it's like we utilize the well-known, well-established animal model to study colitis, which is the acetic acid-induced colitis, for 15 days, and we introduce different doses of DMPNP, along with the positive control of sulfasalazine, to assist different parameters like the macroscopic features of inflammation, the microscopic different markers, myeloperoxidase activity, nitric oxide, and assessment of the spleen proliferation rate by the mitotic activity assay to assess the proliferation as an indication of the immunomodulation of the spleen. Supernatant also of inflammatory markers like TNF alpha and others like nitric oxides, and the gene expression in the samples from the tissue also was assessed. It's like this is like the macroscopic and microscopic features. We found that acetic acid produced a profound inflammation that's like was seen macroscopically and under the microscope, and different doses of our compound resulted in amelioration of these macroscopic and microscopic features, and that was resampling the effect achieved by sulfasalazine. Moreover, it's like we tested the disease activity index to see how DMPNP can improve this parameter, and as you can see, the disease activity was highest in the colitis group and was reduced in a dose-dependent manner, and most interestingly, that the effect of high doses of DMPNP was resampling the effect of sulfasalazine. And the same thing was about the colon length. As you can see, it's like the treatment with this compound produced it's like more effect on the colon length comparable to our positive control of the sulfasalazine. Then we did a metabolic activity assay on the spleen to see the effect of this drug in reducing the inflammation and the immune modulation. And as you can see, it's like the levels of myeloperoxidase activity in the supernatant of the spleen cells and nitric oxide was reduced in the treatment of different doses with DMPNP, similar to the effect of sulfasalazine again. And also, it's like we tested the spleen proliferation rate, and as you can see, the proliferation was higher in the colitis group and reduced in a dose-dependent manner in the treatment group, and the outcome was comparable to the sulfasalazine group. And finally, as you can see here, it's like this is the markers both by ELISA, the protein itself, tumor necrosis factor alpha, interleukin-1, and interleukin-6. All of them, the level of these markers was reduced in the treatment groups compared to the control, and that was like comparable to the current effect of sulfasaline. And finally, the gene expression of these markers in the colon samples also was reduced in all treatment groups, and and that was like very effective and significant at high doses comparable to the sulfasaline group. So in summary, the microscopic analysis showed significant healing of the colon tissue in DM and P-treated mice alongside increasing colon length, which is indicative of a reduced disease activity. And the administration of our drug lead to marked decrease in MPO and nitric oxide level, indicating reduced inflammation and oxidative stress compared to the untreated colitis group. DMNP decreased levels of pro-inflammatory cytokines such as tumor necrosis factor alpha, interleukin-1B, interleukin-16, and suppressed expression of key inflammatory genes like the COX-2 and the nitric oxide synthase enzyme, further evidencing is like its potential as an anti-inflammatory agent. So this study concludes that dimethyl pyrazole nitropyridine demonstrates substantial anti-inflammatory and immunomodulatory properties, suggesting its potential therapeutic agent for IPD. However, it's like we still need further mechanistic investigations and clinical research to elucidate the therapeutic efficacy and safety profiling of these compounds. And I would like to highlight that these data are published recently in the Journal of Future Medicinal Chemistry. And I would like by that to acknowledge my collaborative group who was integral to the achievement of this study. And that's it. Thank you very much. And I'm ready to have your questions.
Thank you very much, and nice study. Tavis, have questions? Okay.
Thank you. When was this study done? I couldn't see the publication date. When was the study actually done?
Actually, this is a published data.
Yeah. I know it's the published data. You could see that from the. But when was the study done? What year was the study?
Actually, it's like in this previous year, in the beginning of the previous year.
How many years ago?
It's about 2 months.
Very recently. Goodness me. Acetic acid. Sorry, one other methodology question. Did you, or when did you use the pyrazole derivative? Did you pre-treat the mice, or did you give them the acetic acid and then give the...
Actually, it's we did a variety of treatment options. One was to start giving the treatment along with the administration of acetic acid, and one option was to, and these results for that options, to induce the colitis, and after that you assess the disease activity, and you start treating with either our drug or the control drug.
Right. Okay. No. But do you imagine that popping acetic acid into a mouse is anything like ulcerative colitis or Crohn's disease?
It's by.
I will answer the question myself. The DSS, TMBS models of colitis have led us nowhere, and I don't believe that I'm afraid that using that model has any bearing on ulcerative colitis or Crohn's disease. I'm afraid. Yeah,
Sure.
it just is. We need animal models.
Right. Yeah, and
but,
it's sometimes there are a couple of available models for colitis, the DSS-induced colitis, acetic acid, or other options, but it's like due to some technical problems, especially
Oh, yes,
with,
yes. No,
our
I'm
part
well
of the
aware of the
work, we have
limitations.
difficulty in getting some of the reagents, so that model was like the best option for us. Along, like, it's like every model has its advantages and disadvantages.
And
But
disadvantages,
this is
but
very
that's a
established.
chemical colitis. It's not an idiopathic colitis.
Just very brief and
Thank
nice
you very
studies. So for a new drug, so for treatment of the IBD, we have two current problems. The first one is supplies. They come up all the time. Travis know very well. And the second thing is they have to use for long term and may have a side effects. So you believe that you just got in the mice model, do you have any possible side effect when you have to use for long terms?
Again, I didn't get.
When you have to use this medication in the mice model, is it have any possible to have any side effects after the treatment?
Actually, it's like we try to monitor just like the main aspects of the disease. We didn't look into the other side effects, or it's just like we were monitoring the disease. I think this will be another step in assessing the treatment option to see and to look into the safety profile of this drug. Thank you.
Thank you, Mohammed, for your excellent work. Thank you very much. Yeah.
Thank you very much.
Now we are going to move the number 4 section. And the number 4 presenter is Dr. Nashiru Luhak Tajidin. He is the PhD candidate of University of Science, Malaysia. The topic he will present is complex and bidirectional interplay between martial quality, catastrophic psychological dysfunction, and quality of life in married Malay women with disorder of gut-brain interaction. Please.
Thank you for the kind introductions. So on behalf of Dr. Hamid and also the rest of the team members, we would like to give thanks to the organizer for giving us this opportunity to present this study on the complex and bidirectional interplay between marital quality, catastrophizing, psychological dysfunction, and quality of life in married Malay women with disorder of gut-brain interactions. So as a disclaimer, I'm no physician, nor am I a marriage counselor, but I'll try my best to present the study on behalf of the team members for today. All right, so for functional dyspepsia and irritable bowel syndrome, they share a common risk factor, which is the female sex. And when we focus on women and DGBI, particularly for FD-IBS and FD-IBS, so there's epidemiological data reported consistent rise in the prevalence of chronic pain among women, also including disorders of gut-brain interaction. So as you can see here from the Rome Foundation Global Study, this is the female prevalence based on the internet survey and the household survey for functional dyspepsia and irritable bowel syndrome. FGIDs in general or DGBIs are more prevalent among women than men. So based on the responses on the internet survey, the odds ratio of female to male is around 1.7, and the household survey, the odds ratio is around 1.3. And this is also similar for FD-IBS overlap. But sadly for FD-IBS overlap, they experience more severe GI symptoms and also depression. So these things are probably modulated by a complex network of many factors, which may include marital status, psychological dysfunction, and symptom severity. So when we look at marital quality, marital status were reported as a risk of FD and IBS in women in several populations, including Malaysia. However, marital status alone is very simplistic, so we might need more precise measures of marital quality to evaluate its effect on DGBI. As for psychological dysfunction, anxiety and depression are associated with DGBI and its overlaps. And in the Malay population, psychological dysfunction often dismissed due to mental health stigma. Symptom severity, the complex of symptom severity could be the product of many factors. One of it is catastrophizing behavior, which can contribute to the worsening of symptoms in chronic conditions. And for quality of life measures has provided evidence for the intervention and management plans of DGBI. So the relationship between marital quality and clinical attributes, which is psychological dysfunction, symptom severity, and quality of life among married women with FD, IBS, or its overlap is unclear. So the aim of this study is to compare the marital qualities and clinical attributes and determine its correlation and path relationships in married women with the said disorders. So for this study, we conducted a cross-sectional study from May 2019 to October 2020 at the Gastroenterology Clinic of University Science Malaysia Specialist Hospital, or HPUSM, which is situated near to Naratiwat. So this specialist hospital serves around 3 million people for the northeastern region of Peninsular Malaysia, which consists of two states, which is Kelantan and Terengganu, and the sampling method is a purposive sampling. So the reason for this particular study, we only include married women from the northeastern region, is to reduce the heterogeneity. So these are the inclusion criteria, which is married women aged 18 years and above, Malay ethnicity according to the Malaysian Constitution, diagnosed with FD, IBS and its overlap based on Rome 4 criteria, living with spouse and self-reported to be sexually active and able to understand, read and write in Malay. While the exclusion criteria is the presence of organic GI disorders and severe mental illnesses. So the dependent variables are FD, IBS, and FD, IBS overlap in married Malay women. So they were required to come to the gastroenterology clinic within a 6-month time frame, and they were required to complete 2 booklets, which takes around 30 to 45 minutes to complete. So in booklet 1, there are social demographic questions, Rome 4 diagnostic questionnaire, and also these marital quality questions, which I will explain later. And booklet 2, which includes psychological dysfunction questions, symptom severity questions, and quality of life questions. For the marital quality, we assessed 8 subscales. The first one is RDAS, which measures relationships, quality, and marital adjustment. And the interpretation is that lower scores will indicate worse marital satisfaction. For RDS, or Relationship Dynamic Scale, we measure the conflict management, which evaluates the communication and conflict management patterns among partnerships or relationships, and higher scores indicate greater marital conflict. PMWISF is another questionnaire we use. So this assesses the psychological abuse experienced by women in relationships. So higher scores indicate more psychological abusive experiences by female in relationships. And MPI is another marital quality questionnaire, which interpreted with higher scores indicating more frequent or negative or solicitous behavior. For symptom severity, we use CSQ-CAT, or Coping Strategies Questionnaire for Catastrophizing. So higher scores indicate more catastrophizing or tendency to have negative thoughts on pain. Psychological dysfunction, we use HADS, which is a common questionnaire. So higher scores indicate greater presence of anxiety or depression symptoms. For quality of life, we use EQ5D5L, which can be divided into 2 parts. The first part is a descriptive part, which higher scores indicate worse quality of life, whereas the visual analog scale can be interpreted as lower scores having poorer perceived health status. So here is the conceptual framework of proposed interactions between marital quality and clinical variables. So this proposed model included the latent constructs for marital quality, psychological dysfunctions, symptom severity, and QOL. And these constructs were chosen according to their relevance to relationship dynamics within the framework of the biopsychosocial model for DGBI. And for statistical analysis, we use path analysis. So path analysis is a generalized method used to differentiate and assess how a set of variables relate to each other or influence specified outcomes through multiple hypothesized causal pathways. Since it's a more flexible model, it allows us to propose and test complex relationships, but it does not establish definitive causal contributions. Yeah, since there's a lot of variables tested, we came up with a number of supported path relationships as an endpoint to suggest the strength of relationships. So meaning more supported path relationship equals to stronger relationships. So here are the results. For the social demographic, we found that the age, duration of marriage, number of children, and monthly income varies significantly among our population. For the monthly income particularly, but for age, it's not really that different. And we noticed that in IBS, they are married for longer years and have more children. So these are the significant differences in marital qualities and clinical variables between different DGBI groups. So as you can see here in FD, they had less agreement with their partners, more marital conflicts, and less perceived solicitous behavior from their spouse. Whereas in FD-IBS, they had higher negative responses from their spouse. IBS group had more catastrophizing thoughts or feelings of hopelessness on symptom improvement and assumes that pain or discomfort will worsen. For FD, they had greater presence of depression, and in FD group, they reported worse overall health status. IBS group had more self-care issues and reported more pain or discomfort, and FD-IBS reported less mobility. So before we do the path analysis, we did these correlation matrices to assess which variables are important for the path analysis. And then after we used the criteria of R more than 0.5, we found that usual activity and also anxiety depression from the EQ 5D5L to be less than 0.5. So we did not pursue path analysis using these two variables. And then when we construct our structural model from path analysis, we find that model 3 is the most relevant model according to our goodness of fit test. And as you can see in the figures here, it's quite complex. So let me just show you one, which is from FD and IBS. As you can see, there's plenty of pathways that is being hypothesized or being measured using the path analysis calculation and models. So what's important here is the number of supported relationships. So from here, you can see that the number of supported path relationship is the highest in FD-IBS. When we look into each of the domains, marital quality is the highest in FD-IBS. Symptom severity is the highest in IBS. Psychosocial dysfunction is highest in FD, and quality of life is the highest in FD-IBS. For the discussion part, we demonstrate that marital quality is associated with DGBI in married Malay women. So we found that consensus, conflict management, negative and solicitous responses were the most significantly affected marital qualities among different DGBI. And the path analysis suggests complexity and potential bidirectionality of marital quality and clinical attributes in DGBI. There are plenty of studies showing that marital conflicts could lead to clinical symptoms and psychosocial dysfunction in chronic disorders. As I presented in the previous slide, FD-IBS overlap had the highest supported path relationships compared to FD and IBS. So this is probably supported by other studies, which they found that FD-IBS overlap tended to have more severe symptoms, worse psychosocial dysfunction, and worse QOL. And FD had more supported path relationships than IBS, but the reason is currently unclear. As a summary, the limitations of this study is that we only involve married patients of single ethnicity from a specific geographical location, but this was done on purpose to reduce heterogeneity. Social, cultural, and biological variables were not studied in this study. So as a suggestion for future study, we might conduct larger longitudinal study with structural equation modeling to infer definitive causality, and perhaps gastroenterologists may consider to screen married patients for marital issues using clinical interviews or objective questionnaires. As a conclusion, the interactions between marital quality, catastrophizing, psychological dysfunction, and QOL in married Malay women with FD-IBS and its overlap is complex and could be bidirectional. So understanding this interplay may direct future family, couples, and medical therapy for better health outcomes in DGBI. I thank the grant and also the patients and staff at the Gastroenterology Clinic at HPUSM. Thank you.
Thank you. It's quite a complex system. Yes, please.
I think it's amazing. Congratulations. That your courage in setting out to do this is remarkable. Do you know whether the marital quality judged by the woman, by the wife, is the same as that judged by the husband?
Definitely not, but that is part of the limitation of our study because we did not assess the husband's responses
Indeed.
as well.
Yeah.
But because these are all questionnaires that is related to their perception towards what their husbands are doing.
No, that's a fair comment. The other thing is the extent, and I didn't quite understand all the nuances, the extent to which the functional gut disorder might itself have been contributing to the poor quality of a marriage. In other words, if you've got IBS, then that might cause marital disharmony. If you've got IBS in one of the pair, might cause marital disharmony.
Yes, this is what the path analysis model is intended to, because it wants to, how to say this in simpler terms, it wants to establish like a general idea of how does the IBS causing marital issues and how the marital issues might.
Okay.
Yeah.
I didn't quite understand, but thank you very much.
Yeah, if no more questions, thank you very much,
Thank you.
Dr. Thakling. Yep. Now we move to the last presenter, Dr. Ryan Juben Diriong from Philippines. Now he is a chief resident of Department of Internal Medicine, De La Salle University Medical Center, Philippines. He is going to deliver a study, a study in topics of unveiling in the Enigma, Banty syndrome, and the mysteries of the congestive splenomegaly. Yeah, please.
Thank you. A pleasant day to everyone. It is an honor to present in this prestigious event, and I am grateful for the organizing committee and Dr. Rona Marie Lewenko, my advisor, for this opportunity. Here are my objectives. So let's begin to unveil the enigma. We are presented with the case of an 18-year-old Filipino female who presented with hematemesis. History started a day prior to admission when the patient presented with 3 episodes of hematemesis with eventual melena and body weakness. On consult, baseline hemoglobin and hematocrit were low, and at our institution, the patient was weak-looking, hypotensive, tachycardic, and with normal active bowel sound, non-tender abdomen without masses or organomegaly. The patient had no known comorbidities and had no history of treatment for tuberculosis or hepatitis and had no previous blood transfusions. There was no noted history of liver diseases or malignancy in the family, and the patient was a non-smoker, non-alcoholic, without illicit drug use or herbal product use. She's annually gravid with regular menstruation. Our initial impression was hypovolemic shock secondary to upper GI bleeding, probably from bleeding peptic ulcer disease, Mallory-Weiss syndrome, or vascular lesions. Empiric therapy with omeprazole and octreotide drip, as well as IV antibiotic, were started, and blood transfusion was done. Here are the baseline laboratories done in our institution, and the non-invasive measures for liver fibrosis were both low. At the wards, there was no recurrence of bleeding, and the patient then underwent EGD. Examination of the duodenum revealed normal bulb and second portion. Gastric mucosa revealed no ulcers, polyps, or masses, no gastric varices seen, and there was noted loss of regular arrangement of collecting venules. Rapid urease test was positive. Examination of the esophagus revealed 3 columns of large dilated tortuous vessels which did not flatten after insufflation. With this being the only identified most probable cause of upper GI bleeding, endoscopic variceal ligation was then done. About 3 rubber bands were deployed. Final endoscopic diagnosis were esophageal varices grade 3 and H. pylori gastritis. Abdominal ultrasound showed normal-sized liver with normal parenchyma. The hepatic ducts and common bile duct were non-dilated, and the gallbladder showed no stones. Pancreas was normal, and the spleen was homogeneous but mildly enlarged. The patient tested negative for hepatitis infection. She had negative ANA and normal thyroid tests, and septic workups were also negative. Drips were consumed post-procedure, and the patient was then started on oral medications. There was no noted bleeding recurrence, and the patient tolerated diet progression. She was then discharged with beta blocker, lactulose, BCAA, and H. pylori regimen consisting of triple therapy with amoxicillin, clarithromycin, and omeprazole for 14 days. The presence of splenic enlargement with subsequent anemia and signs of portal hypertension without any liver pathology or dilation of ducts led to the diagnosis of Banti syndrome. Banti syndrome was first termed by Godibanti, a pathologist in 1894, which he described as portal hypertension in non-cirrhotic patients, and it is also known as Banti disease, non-cirrhotic portal hypertension, or idiopathic portal hypertension. It is considered rare in Western countries, and there are higher reports noted in Japan and India. It commonly affects those in socioeconomically disadvantaged populations with male predominance and usually affects younger individuals. Presentation may be of variceal bleeding, such as in this case, and the patients rarely develop jaundice, encephalopathy, and ascites. And it is important to note that the liver function tests generally are preserved. Several etiologic factors have been proposed, including the congenital and clotting abnormalities, autoimmune conditions such as rheumatoid arthritis and SLE, exposure to toxins and drugs, and infections. Of note, there are few publications about association of H. pylori infection with the development of splenomegaly, and this particular study in Turkey showed that H. pylori positive individuals had significantly higher mean corrected splenic index values and higher prevalence of splenomegaly compared to H. pylori negative individuals, and this suggested that H. pylori infection contributes to increased splenic volume. For the pathophysiology, they hypothesized that the mechanism of H. pylori, it activates the innate and host responses, which initiate a cascade of reaction, and the products are then enter the circulation, affecting the spleen, causing direct antigenic stimulation, which can then cause inflammation of the splenic sinuses and develop portal hypertension by increased portal venous flow. Key issues in the management are the presence of bleeding and hypersplenism, and it's important to address the most probable etiology. Endoscopic sclerotherapy and variceal ligation are effective for acute bleeding, and beta blockers for primary prophylaxis are beneficial. Surgery is only indicated for symptomatic hypersplenism or patients who are not responsive to medical therapy. Prognosis is generally excellent after variceal eradication with a 5-year survival rate of as high as 100%. Currently, there are no consensus regarding the follow-up, but we may recommend treatment based on the ACG and AASLD joint clinical guideline on variceal hemorrhage. So in summary, Banti syndrome is a splenic disorder characterized by the premature destruction of blood cells and splenomegaly, which results from obstructions in the portal, hepatic, or splenic veins, which can be congenital or acquired due to inflammation and infection. Common symptoms include weakness, fatigue, anemia, splenomegaly, and GI bleeding, which can worsen over time. And the management is based on the underlying cause and may use vasoconstrictors, endoscopic hemostasis, or surgical interventions for severe cases. With effective treatment, particularly for bleeding complications, patients can have an excellent prognosis with a 5-year survival rate up to 100%. Here are my references, and thank you for your kind attention.
Thank you for your presentation. Is there any question from the floor? Can you make just a comment that if this Banti syndrome is associated with Helicobacter pylori infection, did eradication of Helicobacter pylori infection will reverse or improve the symptom or the prognosis of Banty syndrome?
Actually, sir, there are no data about the eradication of H. pylori leading to the reversal of splenomegaly, as there are only few limited publications about the association of the infection with the splenomegaly. More cases are associated with other rare conditions such as your Budd-Chiari, some report about PBC, and Felty syndrome or rheumatoid arthritis with splenomegaly. But there are few publications with H. pylori and Banty syndrome. Other infections with more publications include hepatitis and schistosomiasis.
Thank you for your attention. Thank you very much. We close the section.
Thank you.